So the median overall survival of myeloma has been really increasing, in part due to all the novel agents. But now we also have a little bit of an embarrassment of riches because there have been 9 drugs approved in the last decade. And all of these are based on high-quality phase 3 studies published in high-impact journals. And so the question is, when you have so many drugs and combinations, for the community physician who may not be seeing myeloma regularly, it can be overwhelming how to pick amongst all of those regimens. And so what we go through in this segment is basically looking at the phase 3 studies at a high level, the patient characteristics and the outcomes, and recognizing that in oncology in general, outcomes and studies are not just based on the treatment, but they're also going to be based on patient factors like their age, performance status, comorbidities, disease factors like the burden of disease, the molecular biology of the disease, cytogenetics, FISH, GEP, and then treatment-related issues, which includes not only the benefit but the toxicity. So when you put all of those variables together, you really can't compare results across studies because every study is going to have a different population. And what I advocate for is that rather than just looking at the best response rate or the best PFS, is really looking at hazard ratios, because at least within a clinical trial, the whole point of the randomized phase 3 design is to control for a lot of those other confounding variables so you can isolate the treatment effect. And then the hazard ratio tells you the relative value added for the novel agent. And what's good about the hazard ratio is it's not just one moment in time, like median progression-free survival or percentage PFS at a particular time point, but really the hazard ratio of the 2 curves over time, which is the Kaplan-Meier curves over time.